Okay, well, a lot of my questions were answered in the prior session, so I'm going to ask additional questions. So you talked about three therapies as induction therapy versus 4 therapies as induction therapy. So adding isatuximab or adding daratumumab, is that now your standard protocol, and for whom? Do you do it for high-risk patients? Do you do it for standard risk? What about older, more frail patients?
Yeah, I think those are great questions. And what I've gone to doing is the 4-drug regimen for high-risk patients. And then for any standard risk patient who somewhat arbitrarily I consider to have a high volume of disease. And that can be things like 50% or more involvement of the bone marrow, lots of bone lesions, or a high protein from the myeloma. And the reason is that those are people who have a tougher time getting into complete remission with 3 drugs. And so I think, although we're not sure, that the 4th drug really will help to improve that chance. And that's what you really want to do, is to hopefully get into complete remission and be MRD negative. I do think in the future that probably everybody will be doing 4 drugs, at least until maybe one of these disruptive studies, as I mentioned, with a bispecific does maybe better or the same, because you'd rather take 1 drug and get the same outcome than have to take 4.
Yeah, that's a great question and an evolving paradigm. I agree with Dr. Alausi's comments of the increasing use of 4-drug regimens, quadruplets with an anti-CD38 monoclonal antibody to the VRD backbone. I would say I've been using a lot more in my patients with newly diagnosed multiple myeloma with standard risk and high risk. I think particularly based on the recent data, updated data presented at ASH, which is a large hematology conference every December each year. Not only was there an increased depth of response with daratumumab plus VRD, but there's maybe a slight signal of maybe improvement of progression-free survival, although it's very early still and the data is not mature. I think the data also looks very good in the standard risk patients as well. So this is an evolving paradigm. Of course, more data will come out on this, but it's definitely something that we've been doing a lot more. I've been doing a lot more in my patients.
Okay, great. And I also wanted to talk about just maybe to emphasize the point, but also to ask a little more follow-up about the seeing a specialist and the number of clinical trials. So you showed the data that is very clear that it's better if you are treated by a myeloma specialist. When you go to navigate that whole process, how do you suggest patients go about it? Because let's say you're being seen in the community oncology setting and you say, hey, what clinical trials are open to me? And they might not even mention any clinical trials because they're not running those clinical trials. So it's kind of a large process, in my opinion, for patients to be able to say, to have enough confidence to say, I'm going to self-advocate. I'm going to go to my myeloma specialist and say, what are my options? Do you just want to kind of address how you walk your patients through that process?
Yeah, I think that's a critical component of just feeling empowered about your own myeloma care and asking, don't be afraid to ask your doctor where you're being treated, about what treatment options are there, both standard of care and clinical trials. I think it's really important, particularly to ask these questions at sort of every key inflection point related to your myeloma. So sort of when at the time of diagnosis, unless there's an urgent need to be treated, because sometimes myeloma needs to be treated urgently. If you're in kidney failure, there's no time to waste, essentially need to treat it urgently. But if there is time potentially to consider the treatment options, seek the opinion of a specialist. And if you have relapsed myeloma and there's time to make a treatment change, that's a good time to seek the opinion of a specialist, unless there's an urgent need to start treatment right away. Because typically on clinical trials, patients can be enrolled at sort of those key inflection points where they have progression on a recent regimen or they're newly diagnosed. Once a patient is responding already to their regimen, sort of the window of opportunity for most clinical trials to enroll closes, just because, again, most clinical trials enroll patients at these key inflection points.
No, I mean, I totally agree. In fact, we were just having this conversation here with someone who's present here, that do I need to be enrolled on a clinical trial, someone who's under treatment and doing very well. And I said that Probably not at this point, but if the situation changes, as you said, if there is any progression or there is a discussion about change of treatment, that would be the ideal time to discuss clinical trials.
Yeah, I think I'd probably make two other points. First of all, if you go to, let's say, Best Buy, or you go on Amazon.com and you want to buy a TV, well, you don't buy the first TV that pops up on your screen. You do your research. You find out what the screen size is, how much it's going to cost you to operate, whether it fits the system that you have. So we're asking you to do essentially the same thing on what should be a much more important question, which is what therapy and where should I get that therapy? And don't be embarrassed to ask the doctor a question, because if you have a doctor that isn't comfortable answering these questions, or if they don't know the answer, saying, let me research that and get back to you, then I would humbly say you need a different doctor. And the second point I would make is that one of the few good things about the COVID pandemic is that many states loosened their regulations about allowing electronic medical visits out of state. And now that the pandemic is winding down, the restrictions are starting to come back. And this is something that maybe you and others, patients, advocates, can really try to raise awareness about, because why shouldn't you have access to the best possible medical care? Do a second opinion, do it virtually, do it online. That'll make it easier than schlepping a state or two or three states over. Why are there these regulations that prevent you from doing that? These are things that should not be barriers. You can bank at any bank in the country or even internationally that you want. You can put your money wherever you want. You can buy stock anywhere, but why should you not be able to get a healthcare opinion from a doctor in another state if they can help you be comfortable that what you're doing is right, or maybe point out a different opportunity that could be better for you?
Well, I totally agree, because when I was trying to make a decision, I consulted with you and others, and I want to, it just doesn't make sense. I'm going to get on a plane and come fly, but I can't make a phone call or be on a Zoom call. It just doesn't make sense to have the same conversation. So I totally agree with that needs to be changed. It doesn't really make sense to me, because I'm going to get the second opinion with you regardless. Another question. We were talking earlier about some side effects of Revlimid, and I know it's unusual that MD Anderson has a very established Revlimid protocol for some side effect management. And I want to make sure patients, it's such a basic thing that so many people are on Revlimid. Can someone go through that? Because I think it's really unique to your facility.
Yeah, there is definitely a lot of use of Revlimid in myeloma, particularly because a lot of patients on maintenance therapy are on a Revlimid-based maintenance program. And so there are several key well-known side effects of Revlimid. I think one is diarrhea. So GI side effects are common with diarrhea. So sometimes it can be managed with as-needed Imodium that you can get over the counter. There is a medicine called cholestyramine or equestrian. It's a bile acid sequestrant, actually used to treat cholesterol, but actually works really well in Revlimid-related diarrhea. It's a powder that you can mix with some juice, take it once or twice a day. You do need to take it on a scheduled basis to sort of mitigate the diarrhea. You can kind of self-titrate it basically to manage the diarrhea. You don't want to overdo it and get constipated, for instance. So that's one way that we manage the diarrhea. I think the other common side effect is rash. So we often see rashes with Revlimid. And so there is oftentimes a sort of a triple drug over-the-counter cocktail that we advise patients to take, basically consisting of antihistamine-based therapy. So there's basically Pepcid, which is actually a medicine to help treat acid reflux, but it's actually a histamine inhibitor, which is Pepcid 20 milligrams twice daily, which can be given again over the counter. Zyrtec, which is an allergy medicine, 10 milligrams daily. And L-lysine, which is an amino acid, actually 1,000 milligrams once or twice daily is often what we recommend as well.
Okay, great. Okay, I want to open this up to all of you because as patients, you all talked about this, about stem cell transplant, immunotherapy use prior to stem cell transplant, immunotherapy use post-transplant. Patients are trying to make key decisions. Do I repeat the transplant if I've relapsed? Do I do a bispecific or try to get into a CAR T trial? I feel like this is this chess game that we're all playing when I want to make the right move at the right time. But what's it doing to my immune system? How strong will my immune system be if I do a transplant and then try to follow it up with an immunotherapy? Do I have to wait? Like, strategically speaking, let's maybe talk about it first in the relapsed refractory setting about how you do that. And then I have a lot more immune system questions, but maybe we just start with that.
Yeah, I'll let Dr. Quasselbosch answer first since he's our resident transplant expert. So I'll pass it on.
So, but for relapse refractory patient, again, these are the questions that we don't have very clear data. But we do get patients, someone who has had a transplant, was on maintenance treatment, relapse, has had 1 or 2 lines of treatment already, and we had collected enough stem cells to do a second transplant. And then they have this conversation. And again, one very important thing, and I had this conversation last week, that do you have access to a clinical trial? If there is a clinical trial for an immunotherapy, whether it's a bispecific or a CAR T cell, and the patient is eligible, and you saw the promise of that treatment, and they are eligible and it is available, I would strongly recommend them to enroll on the clinical trial. On the other hand, I've had patients who had a stem cell transplant. And again, a current patient like that who had almost a 10-year remission after stem cell transplant and maintenance, and then relapsed, still in very good health, still relatively young and very active. And we had the cells asked, and based on the available data, I mean, these are the patients who can really benefit from a second transplant, can get hopefully several more years, and it won't stop them from getting additional treatments down the road, including immunotherapies, CAR T cells and all. And perhaps we'll have more information about those treatments down the road, and many more will be available rather than waiting to enroll in a clinical trial. So again, these things can be individualized, but in my case, if those trials are available, I strongly recommend, but then in individual circumstances, depending on patient's history, disease biology, one can always make those recommendations.
I totally agree with Dr. Q. I think it really depends on, from a second transplant perspective, how long were you in remission with the first one? Usually, if it's somewhere in the 1 to 2 year or less range, a second transplant is probably not particularly attractive because you will get a shorter benefit. But the longer it is, the more above 2 years, then the better the rationale for repeating a transplant. And we do usually think that transplant sort of resets the immune system, because in part you're killing off a bunch of myeloma. And one of the reasons the immune system is weakened to begin with is because the myeloma does it. That's one of the ways that it survives in your body, is by weakening your immune system. So if we can get that myeloma down to as low a level as possible, often the T cells and the NK cells will come back and be healthier after the transplant than before. It takes a few months. It doesn't happen right away, but you can get there and be healthier from an immune perspective than before transplant.
So interesting. Okay, how much more time do we have?
One more question.
Oh, no, I have so many more. Okay, I have 2 more questions, so I'm just gonna do that. But can you explain how patients should consider strategy-wise? Because now we have 2 approved CAR Ts. The waiting lists are quite long because they're in the process of ramping up production and site openings and all that. For patients who want to do like, how do you think about that? We know that for highly relapsed patients from the clinical trial data, that it has a certain length of life, super response rates that we've never seen before, maybe not as durable as we want yet for those patients who have relapsed significantly. Strategy wise, how do you look at that? Do you say, okay, do I do a bispecific instead of a CAR T for somebody who I think might relapse quickly off of that? Or how do you, and then on the waiting list, what do you suggest for your patients who want to do it right now but can't? How do you manage that?
Yeah, that's a great question. This is a dilemma that we face as physicians in the clinic every week. I think we're all really excited about the CAR T approvals. Most recently, cilta-cel last month, but the access has been very difficult for the majority of our patients. I think that it really depends on the individual situation. If the myeloma is rapidly progressing, where there's not many other great therapeutic options, I think that will itself sort of point you to the direction of taking the best available therapy that's out there. And so I think, fortunately, we do have a lot of clinical trials, both with CAR T therapies that are also promising, not yet FDA approved, also bispecific antibodies. We have a number of them at MD Anderson as well. And so, these are highly effective therapies, not necessarily FDA approved yet, but showing a lot of promise, will likely, hopefully get FDA approved in the near future. And so I think, in that particular situation, I'd really consider doing a clinical trial if there's a need to switch therapy, if there's potentially going to be a wait to get CAR T therapy. So that would be my approach.
I think the good news is that access to these CAR T cells will improve over time. Whenever there's a new therapy that's approved, there's a backlog, if you will, of patients that are eligible, and it takes time to treat them. And then eventually, when the number of people that need that therapy is reduced, you can get them through the system more quickly. We don't have randomized data between ide-cel and cilta-cel to know which one is better. I would frankly go on the first one that you can have available at this point, if your goal is to get a CAR T. And the other thing to keep in mind is that many people who relapse after CAR T seem to still have the BCMA protein, which is what you need for the CAR T to work. And so it may be possible, we don't know this for sure yet, but it may be that, again, sort of along the transplant discussion, if you have a long benefit from the CAR T and then you relapse, you may be able to do that again. And then maybe you switch to the other CAR T next time. So you don't have to look at this necessarily as this is my one shot at CAR T and I'm never going to do it again. So I have to be really right in which one I pick. You may be able to ultimately do both.
Or one after another, or one, yeah, or switch them or whatever. Okay, great to know. My last question is just short. I think we're all very COVID fatigued, but should patients get is it Eversheld? Should they do that, or what are your current recommendations for patients now that most of us have been vaccinated and might have already gotten COVID one or multiple times? But what's your suggestion there?
So, like most of whether it was vaccines or treatment earlier on, it was the issue of availability and accessibility, but now it is available. The recommendation, and I'm talking about stem cell transplant patients, that as long as they are within 30 days of their transplant, they can get this passive immunity and basically antibodies. It's a single injection now, and fairly well tolerated, very little toxicity, and there is no real downside to that. It will perhaps add some more immunity against COVID. So if it is available, I don't see any downside to getting it, especially if it is available to you.
Yeah, I agree. I think there's very little downside. I think we know that the vaccine responses are dampened in patients who have blood cancer, such as multiple myeloma. So I think there is very little downside in getting Evusheld. At MD Anderson, because of the limited access, initially there are some restrictions of who can get it. At least for right now, certain guidelines of patients who recently had stem cell transplant, patients on certain types of treatments for multiple myeloma, including monoclonal antibody-based therapies, such as those targeting CD38s and BCMA. So there are some restrictions internally that we have, but I think there's little downside. The only thing I would, just to keep in mind is there needs to be a gap between when you get, for instance, the booster and when you get Evusheld. So the recommendation is at least a 2-week gap between when you get your vaccine and an Evusheld injection, because the Evusheld could potentially interfere with your vaccine response.
Okay, great. Thank you so much. I didn't have enough time, but thank you.
No, you guys stay up there. So we're gonna do the Q&A. Oh, yes, the audience Q&A. So this is your time. There we go. Think about your questions. This will be like, if you an auction, just give me a little signal or something when you have a question and I'll order you. But this is your time to ask any question about anything you want related to myeloma or world affairs, I guess, if you want. So we will start right here. And I'm going to hold the mic for you, okay?
I'm pretty loud. Okay, the vaccine y'all are talking about, you're not talking about the COVID, you're talking about the myeloma vaccine. Oh, you're talking about COVID. Okay, well, I was going to ask about this vaccine for myeloma. Is that something that's close to happening? And will it help us active cancer patients? Or is it just for the people that are still smoldering?
So right now, the trial that I mentioned is for people with smoldering myeloma, but if the results were positive, which we hope they will be, then it may be something that we would make available to patients with either newly diagnosed or relapsed or refractory disease. But yeah, right now it's unfortunately only for smoldering.
And just one thing to add, having done a couple of vaccine trials in blood cancers, the situation where it works the best, the vaccine, because it has to stimulate your immune system, is generally when you have very low disease burden. So smoldering myeloma would be a perfect setting, or where we use maintenance treatment that after the initial disease burden is significantly reduced, then some vaccine to boost your immune system so it could go against myeloma.
I don't want to share your medical history in front of the world. We can talk afterwards. So.
1, 2, 3. Okay, right. Oh.
Okay. I just had 2 quick clarifying questions, Dr. Orlowski. The BCMA study you mentioned, was that for smoldering or full-blown myeloma patients?
If you're talking about the study with the bispecific that we're planning, that one will be for newly diagnosed symptomatic myeloma patients who are looking for their first line of treatment. And the goal is hopefully to achieve a complete remission. If the patients get treatment, but their myeloma doesn't respond as well as we hoped, then they would immediately be put onto standard chemotherapy like lenalidomide, daratumumab, bortezomib, those kinds of drugs. Yes. So right now it's for newly diagnosed.
Okay, sorry. And then the second one, which is near and dear to our heart, is the scenario 3 you were talking about, where somebody gets seen, I guess, by their I don't know how you describe it, community oncologist, and but was it that they have a specialist at a cancer center, but the outcomes still aren't as good, so they're getting treated in their community, they have a specialist, and that's our scenario. So we're at Texas Oncology in Austin, but we have, we see Dr. Iyer at MD Anderson and Dr. Bashir at MD Anderson.
So
How do you make sure the outcomes are great in that scenario is really my question.
I think a little bit depends on the individual patient and their place in the myeloma journey. For example, if you have somebody who's had a stem cell transplant and they're on lenalidomide maintenance, I don't think it matters whether they're seen at MD Anderson or at Texas Oncology. We're all going to give lenalidomide. It's going to come from the same specialty pharmacy. I think where it does make a difference is where you have a change in the disease. Let's say that there is progression and you're looking for a new treatment. The options at a cancer center are always going to be greater, including clinical trials. And those trials will give you earlier access to some of the exciting drugs than you would otherwise be able to have. So I think that's an example of a situation where accessing the care at a cancer center may result in a better outcome than being in a community setting.
Yeah, in this seriatim of treatment options, let's say you get to CAR-T, Abecma, for example, and you've had 1 or 2 lines of treatment, and then you relapse, come out of remission. Is CAR-T kind of the end of the line, or can you resort back to some of these more traditional treatments that are available?
Yeah, absolutely. CAR-T is not the end of the line. Yeah, in that setting, I really want that to make that clear for you. It's an exciting treatment modality. It's going to be incorporated in the myeloma treatment paradigm, whether it be right now in late relapse disease, but there are trials looking at an early relapse disease, eventually newly diagnosed disease potentially down the road. And so, definitely, I think of myeloma treatment options. We have a lot of weapons in our arsenal. Every weapon is going to be important at some point. And sort of trying to strategically utilize all these weapons, that's important. If you don't use drug X, prior to CAR-T, definitely it's on the table, after CAR-T. So, CAR-T is not the end of the line.
And one thing that we're doing, which I think we're all collaborating on, is a large effort to do this kind of single cell analysis before people get CAR-T and then also after people get CAR-T. And actually, Dr. Patel, who I think will be speaking later today, is involved in this as well. And the goal is really to see how has the myeloma changed as a result of the CAR-T if you relapse, and can you go back, like you're asking, can you go back to get bortezomib, lenalidomide, and dex? Can you go back and get dara? Or do you have to do CAR-T against a different target on the surface of the myeloma cell, or as I mentioned earlier, a different BCMA targeting CAR-T? So right now, we don't really know the answer to that question, to be sure, but we're doing the research to try to figure it out, because we know that at least with both of the CAR-Ts currently available, which are for people with 4 or more prior lines of therapy, that we do need to have something available after that, because although they often have a very long remission duration, and the nice thing is you're off of therapy during that time, which is really cool. Unfortunately, it does not look like either of the CAR-Ts currently are curing myeloma patients.
I'll be up there in a little bit.
This is a 3-pronged question while I have the mic here. One being, for patients who are on maintenance, the percentages of those patients that have other malignancies, can't get the word out, and also of those malignancies, what type is more prevalent? And the third part is, how often, whether a patient is a complete response or partial or whatever, do you do MRD testing?
I'll let Dr. Q answer, since he's part of the pivotal maintenance studies.
Sure. So in terms of second primary malignancy, so if you look at the data, and there are, of course, a number of studies, it also depends on the length of follow-up overall, if you take all second primary malignancies, the average comes to about 8 to 10% if you have a 5 to 7 years follow-up on those. And most of those second primary malignancies, and it's a mix of second primary malignancies. These are the so-called solid tumors, as well as liquid tumors like leukemia or myelodysplastic syndrome, and in some situations, lymphoma. And in those who had solid tumors, most of those were actually superficial skin cancers. But the ones that are really worrisome are the development of leukemia or myelodysplastic syndrome. In general, it's been less than 5%, 2 to 4%, and that takes several years to develop. Average is 4 to 5 years. Some patients, of course, could see that early. So luckily, it's a small percentage, but it is still much higher than the general population. So one has to stay vigilant about that, and we do monitor and look for that. In terms of MRD testing, as we have got better tools at doing those tests, and as we are learning more in terms of what to do with those results, previously patients would do just one set of bone marrow because it has to be done on the bone marrow biopsy. And since in myeloma, we can follow the disease progress just by blood tests and urine tests, we wouldn't do that many bone marrow. But now with the availability of these tests, and we know in some situations what to do with those, or at least we are learning and some clinical trials are addressing, you would see these tests being repeated at least on a yearly basis as more data emerge.
Let me come back there.
I'll just make two comments while you're getting the mic back to you. First of all, we may wind up personalizing maintenance in the future. There's the suggestion that patients with this something called CHIP, or clonal hematopoiesis of indeterminate potential, that they may be at increased risk of second cancers with certain types of maintenance, but maybe not others. This is still only a research tool, but in the future, we may tailor the maintenance based on that. And then, as Dr. Q mentioned, the MRD testing right now is of the bone marrow, which of course is not everybody's favorite test to get by any means. But there are other technologies that are in development, which will hopefully allow us to do this just with a blood test. They will probably not be as sensitive as the bone marrow test, but they will be more sensitive than the blood tests that we currently have. So it'll at least be an improvement.
And this is the last portion of it for sure this time. But what about those patients who you really can't tell where their myeloma may be totally, they may be, is it oligosecretory? So what about those patients then?
Yeah, that's a great question. I think oligosecretory myeloma does present some challenges in terms of tracking the disease, tracking sort of, if a patient is responding well to therapy, or is there some areas of concern on the imaging. So typically with oligosecretory myeloma, I do more in-depth testing for monitoring. So, of course, we would check the blood markers and make sure they're not going up. I tend to do imaging more frequently. So typically there are whole body MRIs or PET scans at minimum every 6 months to track the myeloma, making sure there's no progression on the imaging. And then I would consider also doing more frequent bone marrow biopsies as well. So basically just doing additional surveillance tools to monitor the myeloma.
And we did those for patients who are oligosecretory or non-secretory, because we didn't really have blood and urine tests to follow their disease progress. So those were the patients who, even before MRD testing was done, would get their restaging with bone marrows and frequent imaging studies.
And one quick comment for future studies, it may be possible in oligo or non-secretory myeloma to look at other markers. One example is the soluble BCMA level. This is a test that has, at least in some studies, been shown to correlate well with myeloma levels. And because BCMA is expressed by all myeloma cells virtually, it may be a different blood test in the future that can be used if you don't have an M protein or if you don't have abnormal free light chains.
Yes, I was diagnosed in November of 2020 with myeloma. And ever since then, I've had like 3 back surgeries. Now I'm going through this again to the point where in October 2021, I had a L fusion. And now they want to do they're checking my thoracic part of me, saying that it's not healing. They showed me an x-ray of the bone, it's not healing, but this coming Monday, they want to do a thoracic MRI and a pelvic MRI. I'm trying to figure out what is going on with my spine that it won't heal. When I start physical therapy, I'm fine, but as I get into it, my body crashes. And this done this twice. Is there any damage to my spine as far as for the myeloma? Or what is going on with it?
I think we'd have to know a little bit more detail about your case, but myeloma can definitely reduce bone density. And in some cases, you can get lesions, they're called lytic lesions, where the myeloma literally dissolves the bone, and that can make the bone more fragile and easier to fracture. Sometimes it's not uncommon to hear stories of people sneezing and breaking a rib, or they're carrying just a regular bag of groceries and they get a vertebral fracture. That may be an issue for you. It would be important to know whether you've had bone strengthening therapy. These are drugs like zoledronic acid or Zometa. And then there's a different drug that does that also called denosumab. We try to avoid operations on patients with myeloma unless they're absolutely necessary. I think the other question is, where is your myeloma? Because if your myeloma is very active, it's going to be more difficult for your bones to heal after a surgery. And it may be better to get the myeloma down to a very low level, because then if you get the operation at that point, you will probably have a better chance of having good healing. But definitely staying as active as possible is important as well, because the more stress you put on the bones, it does help to keep them strong. But we do have, if you are interested, there is a bone program at MD Anderson and endocrinologists there who are specialists in, there's a variety of different medications beyond the ones that I just mentioned that can be used to strengthen the bones. So it may be useful for you to be seen by one of those doctors as well.
So I have it's probably a complicated question, but I'll try to make everything simple. So we're in the age of immunotherapies now. And in some ways, it almost seems like some of the therapies are getting ahead of maybe even some of the basics. And so I never hear, even though I'm involved with immunotherapies also, things about conditioning your immune system. So we hear things about, as you age, your immune system decreases, and there are tired T cells potentially that makes T cell therapy not as effective. There's things like inflammation. Does that actually kick off the smoldering myeloma into myeloma? Or gut biomes may actually have an effect on stem cell transplants and other things. And even vitamin deficiencies, some powerful, the Mayo or everybody in the US or Northern Europe seems to have vitamin D deficiency, and that has all kinds of benefits for immune systems. So I'm not aware of protocols to condition your immune system. Though you go on the internet and, I can buy a powerful, supplement, who knows where it's from and what's in it, and make my immune system better. Though there are other standard ways to improve immune systems. And so the question I have actually is, are there protocols? Are there resources even, this maybe even for Jenny, to help the patient help the doctor with immune therapies?
Yeah, this is a great question. There's so much that we are learning as we speak about the immune system, the gut microbiome, as you mentioned. There's so much more that we need to learn, and there's ongoing studies looking at this. I think a great example of what you're talking about is, Dr. Manasan, who spoke earlier, she ran a smoldering myeloma clinical trial with this PD-1 inhibitor pembrolizumab. And actually, I think there's 12 patients enrolled on the trial, and 11 patients had stable disease, essentially did not have a response. One patient had an exceptional response to therapy, essentially complete response to single agent pembrolizumab, which, this particular drug, those who know the history of pembrolizumab myeloma, was initially very exciting, particularly in relapse refractory myeloma, but there's some toxicities which sort of dampened the enthusiasm. But the question is, why did that one patient respond incredibly well to pembrolizumab? Essentially, it conditioned the immune system to basically fight against the smoldering myeloma. And we don't know the answer to that question, but there's a very provocative case that, there's something there. There's absolutely something there. This is where we need to do more research, in different stages of myeloma, smoldering myeloma being that one example.
I think the short answer to your question is that there are not firm recommendations because we don't have enough data to know what to tell you to do. We would love to be able to tell you which probiotics are best, what diet is the best, but we don't really have that information. There are data from other cancers which do show that the microbiome, for example, which for those of you that don't know that word, it essentially means what bacteria do you have in your gut? They can impact responses to immune therapy. And there are some studies now looking at whether if you change that to a more favorable, quote unquote, versus unfavorable, will that mean that your response is better? But in myeloma, we don't know yet. Dr. Patel, who will be speaking later, one of the things she's looking at in the CAR T area is that we're also collecting patients' poop and doing studies on that to try to see if there is a correlation between outcomes and responses and what the microbiome looks like. So we leave no stone unturned. But right now, we just don't know what to tell you. I think your point about vitamin D is a very good one. I think probably everybody in Houston, especially in the summer, is vitamin D deficient because it's so hot and humid, nobody wants to go outside. But definitely maximizing your nutrients and vitamin D is probably part of that.
No, I know, as you know, we all get asked this question a lot, and I do too. And as Dr. Orlowski said, the simple answer is no. Of course, there are people who's a multi-billion-dollar industry where people are strengthening your immune system and helping you with your diet and nutrition and multivitamins and all that good stuff. But in terms of scientific data, those are not there. And where they are for very specific conditions in very specific population in very small percentages, which just cannot be generalized. That won't stop this industry, but that's the answer. Yep.
So the gap, it seems to me, is the pharmaceutical companies don't really pursue this because it's over-the-counter kind of solutions. They don't make a lot of money. And so I'm not aware of, other studies where it's maybe not the pharmaceutical companies, but maybe it's the research institutions or some sort of other entity that maybe isn't funded properly to help advance some of the data that would suggest, maybe helping with the immune systems.
Well, so first we have to know what exactly the immune system is wrong or what needs to be helped, right? So I don't think that there are that kind of data available. Sure, there is an important role, especially with the emergence of immunotherapies like checkpoint inhibitors and the role of microbiome, whether it's in response to immunotherapies or in my field, in the treatment of graft versus host disease, how these gut bacteria help. But again, the data are limited. We don't know exactly. These are very complex systems. There are way too many components. And when you look at just one isolated thing, and if it is up or down, and by fixing it with something, it's probably not going to make that much change in that complex system. So we do not know that much about the immune system.
And it does take time for the research to get done. CAR T cells, the concept has actually been around for a long time, but we didn't understand enough about how T cells work and how to manipulate them until the last few years. And I think we're still in those early days in terms of the microbiome, but I would definitely expect that 5 years from now, hopefully, we would have more information. And I wouldn't be surprised if pharma isn't a big player there, because they would be more than happy to put together some kind of proprietary mixture of bacteria that would improve the efficacy of cilta-cel or ida-cel or one of the bispecifics, as would we all. So I think it just takes time for the field to mature. We're all very impatient about that because we want the answers now, but unfortunately it does take time, which gets back to supporting research.
Somewhat related to this, I received a question from an online viewer by email earlier today, and it fits here. And it's a question we get a lot about diet. What does a vegetarian or a vegan diet help in any way?
I think from a myeloma perspective, the best answer is, again, we don't know for sure. The only thing we can say is that there are no data that suggest that one diet is better or worse than any other, but there may be other health benefits to a vegan diet compared to one that is, for example, heavy in carbohydrates or heavy in fats and proteins. And I know I could certainly use to lose a few pounds myself. So I think we could all probably be a little bit healthier.
Is there a Whataburger immune system booster?
We in stem cell transplant for chemotherapy in general, but because our chemotherapy is so much higher dose, there was this neutropenic diet, and we would deny patients fresh fruit, vegetables, dairy products, and it doesn't make any difference. When the studies were done, whatever the quality of studies, did not show any benefit. So of course, no one follows that. We at one time had a graft versus host disease diet. And again, patients who had gastrointestinal side effects, we would tell them not to eat certain things that they would crave or would really like to eat. And again, that did not have any impact, and we do not use that anymore.
Yeah, I'd just like to say that that's a really common question I get in clinic is, what diet should I have? Is there a particular diet that works better, against my myeloma than others? And in the absence of definitive data, I do not make any specific recommendations. I don't want to, potentially lead to more stress, right? I ate a cheeseburger today, it made my myeloma worse. I ate broccoli today, it made my myeloma better. I mean, this is like really stressful. It can be really stressful for patients, and I don't think that's unnecessary. I do say though that, because, and this is a good thing, myeloma outcomes are improving dramatically over the last 10 to 15 years. Patients are living longer and longer. And so it's, really important to eat healthy, heart healthy diet. If your myeloma is doing well, you don't want to potentially have other problems, whether it's cardiovascular risk, diabetes and things. Even though you have a diagnosis of myeloma, think long-term, don't neglect your routine health screening. Don't neglect your primary care appointments. Don't neglect your cholesterol. So these are all important things that ultimately help your long-term health.
Yes, I'm a new patient to myeloma. Last year, I was diagnosed on the upper end of MGUS and lower end smoldering myeloma. I understand the vaccine study is for the treatment of smoldering myeloma. And you mentioned something about a risk of progression. Did I understand that the personalized molecular profiling is a way to determine the risk of progression, or did I miss that?
So there are a number of different systems which use different prognostic markers to put folks like you into low, intermediate, or high risk. One of the frustrating things is that you can take the same patient and different systems will put them into different risk categories, which just shows you that we don't know enough about it. But what we found is that one of the most accurate is to do something called gene expression profiling. And that is available. So that may be something that you may want to avail yourself of to get a better idea of where you stand on the spectrum. Because if you're at low risk of progression, frankly, you may not even want to consider a trial. Whereas if you're in the intermediate or high risk categories, then it may be worth doing. The same thing is true in MGUS, although in quote unquote high risk MGUS, your risk of progression is maybe 3% per year as opposed to 1%. So 3% is still a pretty low risk, although that's not a lot of consolation if you're in the 3%. Sure.
Wait.
I can repeat the question.
No, we got it. We need it for the online audience.
Gotcha.
Relative to participating in trials, unfortunately, I've been diagnosed also with a MPN essential thrombosis. Does that prevent a patient from participating in myeloma trials going forward as the disease progresses?
A great question. It depends a little bit on the individual trial, but many studies do exclude people that have a different cancer diagnosis, in part because there is concern that therapy for one disease could potentially impact on the outcome with another. So it is something that you need to ask on a case-by-case and trial-by-trial basis.
We're going to have two more questions.
The question is, and correct me if I'm wrong, theoretically, if you had a second autologous stem cell transplant, it may not last as long as the first one. Okay. That being said, if a patient has had 2 stem cell transplants and say after the second one, even though they're on maintenance therapy, they may relapse, say within 2-3 years. What would be the recommendation at that point for that patient who may be at that point 12 years out into myeloma? Would it be CAR T, BiTE therapy, or looking at some of the other things that may be coming down the pipeline?
Yeah, it's a great question. I think this speaks to how rapidly the field of myeloma is evolving. The answer I give in 2022 may be different in 2023. A lot of it depends on the treatments you've been exposed to before in the past and what you've been resistant to before in the past. But assuming that you have been exposed or resistant to some of the currently approved therapies, certainly doing a novel therapy such as a bispecific or a CAR T type therapy, would be a consideration, particularly if either you meet the criteria for standard of care therapy, once, for instance, bispecific gets approved, or the standard of care criteria for CAR T, or a clinical trial potentially as well.
The only other editorial comment that I would make is that it is worth reassessing your molecular risk profile if that's a situation that you're in, because normally we would consider somebody who is 12 years into their journey to be a quote unquote good risk patient, because high risk patients unfortunately usually have a shorter survival. But risk can change, and sometimes you can have a quote unquote good risk. I say that because there's nothing good about it, but you can have a good prognosis. And sometimes because of new mutations or because of emergence of a myeloma clone that was very small at the beginning, but then grew, you can then develop a more high risk type of myeloma, and that can impact prognosis as well as treatment selection.
And this will be our final question. You knew Jenny would figure out a way to work in one more question.
I know, hog the mic. Yeah, I'll hold it. So I was just wondering, we talked about like immune system status and kind of measuring that. And sometimes you're looking at the microbiome or whatever other factors are part of that immune system. Is there a standard way that you can measure immune system status to see, oh, this treatment may work or not work? And then going back to your single cell RNA study, how can we as a foundation help contribute to more samples or inviting patients to donate, those types of things to help advance that research that you're doing in the precursor condition setting. And then also, you're saying we want to test things after people are done with CAR T, or how do we facilitate that more for you?
Well, the first question has an unfortunately easy and brief answer, which is no. We don't have standard ways that we can assess the immune function. We can look at immunoglobulin or antibody levels. We can look at ratios of various types of T cells in the blood. So we can have some idea, but it probably isn't yet at the level of precision that we really need to have. And then in terms of how foundations or patients can help with this effort, first of all, we, of course, always would appreciate having patients who are looking for CAR Ts come to our institution, because then we can collect the samples that we need to do that. But if there would be an opportunity to set up this kind of collaboration with other centers with support, that would be great. Krina is already one of the leaders of a consortium of about 10, and ultimately it's going to be about 20 institutions that are putting their CAR T data together. But as of right now, those are the clinical outcome data, and we're not yet at the point where we're getting samples, which would be the next step. So maybe that would be a good way to step in and help out.
Well, thank you. For our online audience, well, before I say goodbye to our online audience, first of all, thank you for our morning session, doctors. Dr. Lee, you didn't know, Dr. Massac unfortunately had to cancel this morning. So we made Dr. Orlowski earn his fee and put him to overtime. So I'd like to thank our morning faculty.